Okay, Dr. Dave Webster, and this is part of my ongoing video blog series about the travesty of patient access to PET-CT in our liberal so-called evidence-based and, believe it or not, patients-first healthcare system. So previously I'd talked about the government's special efforts, the Liberal government along with their Cancer Care Ontario medical experts, to block breast cancer patients in Ontario from PET-CT because they decided they didn't want them to have access to it, and yes, it was because of money. Now, if you haven't seen that one, it might be useful to do so, and it's on my YouTube channel, Dr. Dave in capital letters and then Webster, and please subscribe to the channel and like it. We need to get this information out if we want to bring about any change, and if you're concerned about what you're seeing, it's the only way it's going to happen. It's not going to happen to the press, as you would have already guessed. But that particular video, PET Predict Impact, Summary and Impact, there's 3 videos, I believe, on this, the PET Predict trial and what was done to breast cancer in Ontario, but that will be the summary. So in this video, I'm going to talk about why men with prostate are now the government's next group for special attention from Cancer Care Ontario and the McMaster colleagues. I know that is in process as I speak. So this is going to be part 1 in the interest of time. So what we're going to look first of all is the Liberal healthcare formula for what they will fund with OHIP. So it turns out step 1 is simple. The Liberals decide over coffee and donuts, I guess, what indications they're going to fund for fund OHIP for PET-CT, and then step 2 is Cancer Care Ontario and their McMaster evidence-based medicine expert colleagues will then come up with the answers the government needs to implement the policy. Sounds like a conspiracy theory, if only it was. Now, it's pretty obvious. Anyone think the Liberals might be using this formula for other critical healthcare decisions for funding in Ontario? You bet. And it's as simple as that, this 2-step process. Now, the PET Predict trial, just to summarize quickly, it was no question an assault on Ontario women with breast cancer. And by the way, this trial finished on 2007, and it was determined to be not only unethical but bordering on immoral. Continues to this day to be the excuse by the Liberal government to block women with breast cancer from access to what may be a critical PET scan that their physicians in Paraguay would know that they would benefit from. So it was designed deliberately to fail, which is an unethical principle outright with ethical trial design. Why? Because the government decided they weren't going to pay for it, so they decided to fail. And then the second thing they did in a big ethical bad way, which again unethical, defining it unethical, was that instead of immediately stopping the trial when it became obvious it wasn't the trial was going to fail. I mean, that's what ethical principles said. It's called equipoise. But the point is, it was designed to fail. It was immediately obvious that it would fail because that's how it was designed. But instead of stopping it, they put over 300 women terrified with their new diagnosis of breast cancer through this trial, exposing them to non-trivial amounts of radiation from the test, and of course an enormous unnecessary stress to these patients. What it translates to men and women with breast cancer in the provinces of Ontario is that you simply have a greater chance of dying of your disease, and sooner than you might if you, for example, lived in, I don't know, Turkey, Chile, and Argentina. Now, what about PET and prostate cancer? Unfortunately, FDG PET was a disappointment. It wasn't very helpful in prostate cancer, and so there was a search on for many years, like decades, looking for something. They used carbon-11 acetate and something called F18 choline, but neither really turned out to be particularly useful. But now, and I cannot overemphasize that there really is a revolution occurring beyond the borders of Ontario in how prostate cancer is not only going to be detected by imaging, but also it's tied, as you will see, very closely to therapy. And that's something called the prostate-specific membrane antigen, or PSMA for short. Now, for those who haven't seen my video describing what antigens are, it turns out that all cells, whether they're normal or cancer cells, have on their surface antigens as an integral part of their structure. And these antigens are typically proteins which actually pass between the inside of the cell and through the cell membrane into the outside world, so the inner world is connected to the outside world through this protein antigen, and on this protein also are molecules which stick up, which are made of various other molecules, proteins, carbohydrates, and so on. Now, they're not only found in the cell surfaces, but they can also be found in the blood. blood, and you'll see how, and you're already familiar with, I'm sure, some of these things. But the point is this here is a normal cell, the nucleus. This is the cytoplasm of the cell, and these little things poking through the membrane here are the antigens. Looked at slightly larger, this is the inside of the cell. These are these proteins going through the cell membrane wall, inside world, outside world, and these are the antigen with the different carbohydrate side chains attached to them, and they're unique, as you will see, for some have very specific functions, normal functions of the cell. Others are specifically associated with cancers, and you'll see this one in the case of prostate cancer. So let's just look at the male reproductive system here for a moment. This is the patient's bladder here. This is the rectum and the spine. This is a cut through the side of the patient, obviously here. And this is the prostate sitting at the base of the bladder. The urethra passes through here and then out through the penis. Now, this is just some diagrams of stage 1, 2, and 2, 3, and 4 cancer. This is invading right into the breast or through the bladder wall and so on. This is the advanced stage and would often be found not just extending beyond into the bladder, but also at other spots in the body, a stage 4 disease. If we were to look at it under the microscope, these are the kind of cells you might see, these blue stained cells here. And for those who have or familiar with prostate cancer, you'll have heard of the Gleason scoring system for pathology. I'm not going to go through that in this particular video, but let's just go back at again. We've got the prostate cancer picture here in the cells, but most people have probably heard, and certainly men will have heard of something called the PSA test to screen for prostate cancer. Well, what exactly is PSA? Well, guess what? PS stands for prostate specific, and does anybody want to guess what the A stands for? And of course it stands for antigen, PSA antigen. So it's one of these proteins. So if we look at these cells here, on the walls of these cancer cells will be this little funny looking sort of protein here. There's a helical regions and so on. This is how we would make a diagram of it, but this is a molecule of the antigen PSA. Now, on the other hand, the molecule we're now talking about is in fact a PSMA. It's a more complex molecule, as you can see, but again, it's found on the cell's surfaces, and this is what we are going to be attaching our imaging agent to, as you will see. Now, what about the incidence of prostate cancer in men, and especially in our aging population? Many people aren't actually aware of this, but if we look at the age variation in cancer incidence, this is starting at a young age and going to an older age, and we see breast cancer here in the kind of pinkish hue here, and the blue here for prostate cancer. What you can see as we age, breast cancer does occur at a younger age, but as we get into the older age population, right here we can see around the 60 age group, prostate cancer is now more common as a cancer in men than in women, as far as cancers go in men and women. And here we see more than twice the amount of men in this age group here in the 70 to 74 will have prostate cancer compared to women who will have breast cancer. And the next thing is that if we look at the age variation in cancer mortality, in other words, dying from cancer, you can see a similar pattern. We see, although women will start dying of breast cancer at younger ages, by the time we get into the older age population, the death from prostate cancer in men greatly exceeds the death rate from breast cancer in women. And men, of course, they also can get breast cancer. And one of the big reasons is we've got a lot more effective treatments for breast cancer than we do for prostate cancer. Although, as you will see, this prostate-specific membrane antigen seems to be just opening the door to us now beginning to have major impact on treatment and survival of men with prostate. So in summary, what we see here is that although prostate cancer starts later in life than breast cancer in women, the incidence is higher eventually than breast cancer that we find in women. Now, in addition, the death rate from prostate cancer in men is much higher than it is from women with breast cancer. So this is the end of part 1, and please carry on and look at part 2. Thanks, and see you in the next video.